We spoke with an ACO that serves the post-acute space. Patients seen in skilled care, place of service code 31, are limited to a short stay and are excluded from attribution. Though the intent is to get them home after a short rehabilitation, many are discharged to long-term care, place of service code 32, which has no limitation on duration and is eligible for attribution. The ACO continues to provide care to these patients for the duration of their stay in long-term care. This ACO finds that many of these patients discharged from long-term care to home after a few months do not establish with a community primary care provider and remain attributed to the long-term care providers who don't have a venue in which to continue serving them post-discharge. Are there any specific strategies or best practices you'd recommend to address this attribution challenge?
Oh, great question, Jason. I can see how those patients become a risk to an ACO's cost performance. Controlling that risk is a challenge. Now, I see two domains to start thinking about how to address that risk and contain it, control it. The first is discharge planning, upping your game in that area. And the second is to improve that transfer in responsibility, solidify it, systematize it. On that transition from long-term care to home, one set of risks is to the daily care plan. On the transition to home, there's dramatically less supervision, monitoring, and supportive activities of daily living. Compliance levels do change commonly and sometimes dramatically in terms of exercise, diet, and medication. Costly events become more likely, mostly related to decompensation of fragile chronic conditions. But falls and other injuries also contribute to the risk of high cost events. And with those events, of course, decompensation of fragile illnesses, major injuries, rehospitalization is a very costly event that affects this population. Now, control this by upping your game in discharge planning. Mobilize the family and mobilize community care teams. Take it seriously in every discharge. Never assume it's going to be smooth or easy. The other risk is to get lost to medical follow-up or simply confused or delayed in the transition. Prior studies have shown that people who have a primary care provider, know who it is, and have access to them enjoy better care and lower cost of care. So getting lost in that transition can be a risk to the cost and quality of care, essentially. Control these risks with better planning for the transitions. I suggest meeting with regional primary care providers to secure agreements that they accept your patients on transfer to home and that you together outline the expectations, who does what when the transfer happens. Now, you should consider as part of the handoff an annual wellness exam through the new primary care provider. Suggest it, insist on it. It would nicely facilitate both the transition of care and the transfer of attribution. An annual wellness exam is a great review of the patient's comprehensive needs, a great introduction to a new provider, and its billed performance takes precedence over most other triggers of attribution. So with that one move, you make the transfer better, more solid, and affect that transfer of attribution that you'd like to see. Now, consider facilitating the kickoff of that annual wellness exam within your own discharge process. Distribute or even administer a standard risk assessment tool, leaving the final analysis and billing for the service to the new PCP. As an additional solidification of the transfer of attribution, consider helping the patient name the provider who is accepting the patient in transfer as their new primary care provider through Medicare.gov. In most cases, this prospective attribution takes precedence over all other methods. Now, some reasonable combination of these approaches that I outlined is simply good health care and effectively transfers the care and responsibility and can facilitate that transfer of attribution to the new provider so you don't suffer from any other cost events that come down the pike for those transferred patients.